Hello, I'm Tony Das. I am one of the founding members of VIVA Group. We are a multidisciplinary group who's dedicated to the care of the vascular patient. It's our feeling and our heartbroken sentiment that this coronavirus 19 pandemic has affected all of us, and especially the patients that we care about so much. It was a desire for us to get in front of people, to be able to share best practices, and for us to be able to learn from each other. And we wanted this Zoom conference to serve as a springboard for us to be able to open up the conversation so the experiences of many could be really the part of improving the care of these vascular patients, as well as seeing what we can do to help each other to be able to get through these times emotionally. What I'm going to do is introduce our group here. I'm going to start at the bottom here, Dr. Raghu Kalluri, who is the Director of Vascular Medicine at the Ohio Health Riverside Methodist Hospital. Dr. Cyrus Sabri, MedStar Washington Hospital Center, Interventional Radiologist Extraordinaire. Dr. John Runback at Advanced Interventional Vascular Services in TNAC, and Dr. Nitin Singh at Harborview in Washington. I'm going to start with you, Nitin, because I think that your experience, even though slightly earlier than the rest of the country, really has taught a lot of us about what this rapid progression of this pandemic has done to centers with respect to what they're doing for resources, what they've done for cases, how they're dealing with vascular patients. And we'd really like to just open up with you giving us your perspective in Washington about how things opened up and started there, if you would.
Thanks, Tony. Actually, you're correct. I mean, we had the first case here in the Seattle area, and we knew things were starting to get bad as we saw the numbers rise, particularly at a particular retirement home or skilled nursing facility. And as those numbers began to rise, we noticed our division or department chairs telling us now that all meetings were canceled. So we were not, those things became travel restrictions were now being enforced on March 9th. That week we began to prepare because it was told that we need to start identifying cases that needed to be completed and avoid any elective cases. Still not really wrapping our mind around it as much as we thought. So we started putting our list together of cases that we felt we should be doing, which were aneurysms greater than 5.5, CLTI patients, dialysis access and maintenance, and symptomatic carotids. Our opinion really changed after speaking with some Italian colleagues and understanding what they were going to. They were probably about 10 days ahead of us where we thought we would be on the projections. And they said at that point, 90% of their hospital was filled with COVID-19 patients, and everything was all about COVID-19 patients and conserving resources, and they were only doing emerging cases. So we quickly adopted that in our division, and we shut down everything. I had a few critical limb ischemia cases going on that week, and at that point I canceled them. The aneurysm cases were canceled. And we just went to emerging cases. So over the weekend, I did a ruptured aneurysm patient. The other case that happened was my colleague, Dr. Starnes, had a patient who had a gunshot wound to the carotid, and he did a repair on that. So truly just switched to that over that time period. But this is a mentality change. At the beginning, you want to know if you're doing the right things, and you're having to talk to families and tell them that we're going to have to push your case out a couple of weeks at least because of the resources. But our hospital really appreciated that because soon enough, masks were hard to find in our hospital near our operating areas. And, these are real events. People were taking masks. People were nervous about it. The hand sanitizers became more obsolete. And, in understanding in big systems that we all have to contribute. And I think that it's hard as people that are used to doing interventions and procedures to save lives and limbs. We had to change our mindset and say, let's back off of that because right now we have to conserve resources because, if you really think about the procedures that we do, we really put a lot of resources to use. I mean, a lot of the PPE, and not only that, it's the exposure. Our patients are generally in that age group where they're the most vulnerable to exposure and having a bad outcome with a contraction of COVID-19. And with those things in mind, we really adopted that over the last couple of weeks. And in thinking about that, we have an education program. We have fellows and residents we have to teach. And so now we've gone at our hospital to having one attending on with one resident, almost acting like it's a weekend. People come in and get out of the hospital. Nobody stays in the hospital. If a patient, if consults can be managed telephonically or electronically, reviewing images and talking to a consultant, we do that. So we're not seeing the routine things that, you're so used to just seeing and calling for a study or getting, going in and seeing a patient. Those are being avoided right now. We've created the platforms, a lot of Zoom educational platforms now to have conferences and educational didactics done over a Zoom platform, which, I've been very, very enthusiastic with how our residents and trainees have all adopted to this. And we've had some great lectures going on over this week and trying to maintain the education, theme that we have to have in these centers. But, overall, we've noticed a difference right now at our hospital. Our hospital at Harborview is used to running about 100% always, usually 110%. But right now we have 30 ICU beds available. We have 14% less admissions based on the decrease in the elective cases that are going on. So, we're building capacity because our expected surge is supposed to occur. Now it's looking like it's more along the lines of April 12th to 19th. And so and sometime in that time frame, we've got to be ready to make the switch. We're having residents and other faculty members cross-train because they're going to probably have to cover in the ICU or in the emergency room or wherever we're needed. It's a call to action, but it's a call to action to almost sit on your hands as far as being somebody who's used to doing interventions and procedures. So, I think that we are a little bit ahead of people, and I think there's different ways things are being managed at different locations right now. But that's how we're doing it here, and I think we're probably a little bit early on the frame, but than most people. But I think everyone's heading towards that as I talk to people around the country.
Well, thanks so much, Nitin. That's so helpful for us to just understand. The other thing that you described was that, in the beginning of March is when this started, and you're thinking that it's going to be about the mid part of April when you're going to see your surge. We start to see some timelines that are helpful for the rest of the folks in the country. Sarah, let me go to you on the opposite side of the country there at the Washington Hospital Center, and give me a sense a little bit of how you guys are managing resources and other challenges that you've already faced and in your leadership role, what you've been able to do to overcome some of those.
Yeah, thanks, Tony. We've learned a lot from talking to our colleagues in Seattle and in New York now, how they're managing their resources, how they manage them. We're probably a week or 10 days behind Seattle from what I can hear based on the numbers, and we have, somewhere between 45 and 50 cases or PUIs in our hospital now. So trying to think ahead that where the surge is going to be and when it's going to happen. So we started doing similar steps to what you heard from practices in the West Coast. The first thing we start with elective cases and trying to slash these numbers as much as we can. But then there's a lot of inpatients in the hospital that they still come in for different types of procedures that they're needed. And as interventional radiologists, we still deal with a lot of venous access. We deal with a lot of cancer patients that they need their treatment and they cannot be delayed. And this is where you try to kind of do this triage process. Where does the vascular patient fall into this versus a cancer patient? Who gets a priority to be treated? And we have to make some difficult decisions, or who we delay and who we don't delay, and how long do we delay them for? So this triage process gets tighter as you go through the process. Early on, we still did some dialysis work and some vascular, CLI, early ulcers and such. And now we're moving towards being more strict with this and heading towards what we heard on the West Coast. Still on the cancer side, for example, we're still treating a lot of patients, but I think soon enough we're still gonna head into the only emergency cases. The thing that's very important is, especially talking from colleagues in New York about the resources and the PPE and how short they are in equipment, and just hearing about some simple things that we're just used to, like masks and gowns, and how they are completely short of gowns at this point, and how they are forced to do certain procedures without even using gowns. So just with that in mind, we have to start rationing our supply of PPE at this point. So we started doing some processes where we decide what procedures we will do with full PPE and which we would not. I think it's really member scrum for every case. And that was a very important step to take to say this is the number of gowns that we're going to use for every case. No more than 2 gowns, regardless who's in, try to limit your in and out of the procedure. We're so used to scrubbing in and out and reviewing and getting back in. So all these things, you just have to think ahead and have a plan for it. Also, now we have a plan written for if we have a PUI or a COVID positive patient that's coming to our area for an intervention. Speaking to our colleagues in Italy and in Singapore and China who've done some procedures on acute limb ischemia who are positive, or stroke cases, and so coming through the unit to how to plan it, and there are a lot of resources that are available. I encourage everyone to look into them to see how you're going to plan that and have everything written up, and all team members know their responsibilities and how to do such a procedure. So these are things that we're looking into. Supporting our staff in this process is very important. Everyone is anxious, so it's important as leaders to talk to them, to explain to them how we work so hard to protect them in this process. And knowing that cases that are positive, that are going to come into our units, are going to be a very rare occurrence. But we have to be vigilant, and we have to prepare for the inevitable that we may have to do positive cases, and the reason why we have to ration our use of PPE. These are some of the things that we worked on, and I think we keep learning from our colleagues in other areas, and I think it's important to see a different end of the spectrum. We have emptied our ICUs and our floors, and we are waiting for what's going to happen. And so, similarly, you have to have an A team and a B team, and send some staff home to be ready for what is to come, and try to manage a lot of education activities remotely.
All right, thank you. That's very helpful. Raghu, I wanted to ask you, you direct a large number of vascular labs in your system, and you used a term the other day when we were talking called intensive vascular medicine. Can you tell us a little bit more about what that is and how we might learn from that?
So the vascular lab situation and intensive vascular medicine situation, those are 2 different issues that we had talked about. Tony, thank you. I hope everyone is trying to stay safe. We are a little further behind than the East Coast, like you, Tony. We're in Middle America, so the surge is probably 2 to 3 weeks from now, so we're trying to prepare for it. Let's talk about the vascular lab team first. Nitin and Sahar have already talked about what procedures are being done. So the vascular lab, which is the foundation for any vascular service, needs to be prepared for that. So, one of the first things that I looked, that I thought about when this came on is to, kind of protect the patients from the sonographers and protect the sonographers with PPEs too, and have that team A, team B kind of situation. But it's easier said than done, because, as physicians, we are at a different, level in terms of managing the team A, team B concept. But as the vascular sonographers, most of them are on hourly wages, and that's a different dynamic that we need to go through. And how to maintain that balance so that you don't have the COVID-19 decimate your entire sonographer service, but at the same time make sure that everybody's getting paid. So it was a fine balance in managing this across the 15 vascular labs that come under my jurisdiction. Each place is different, and how can we use all of them in different areas who want to be used, and how do we keep people who want to use their vacation times, during this time, let them do that. Those type of things were quite challenging. We stopped doing any elective testing, surveillance testing, venous insufficiency testing, stable claudicants, and all of that, we're no longer doing in the vascular labs in the outpatient world. In the inpatient world, we're just supporting what you guys have just said: critical limb ischemia, acute limb swelling or pain, DVT, or dialysis fistula, clotting, and all that stuff. And then, acute intestinal ischemia, if a CT cannot be done, or rapidly expanding AAA that was not visualized on a CT. Everything else, my sonographers, my lead techs from each of these sites have the phone numbers of our lead medical guys in those areas, or mine, if they have any question. And it's a case by case. I mean, Nitin and I were talking about it. If it is a swelling, can that patient be treated with anticoagulant without having to do a duplex? What are the bleeding risks? So those are the type of things we tell the sonographers. The threshold is really low now for them to pick up the phone and call my cell phone. I receive, several calls every day to kind of triage these type of things. And unless we're supportive of our sonographers, both, with these type of medical judgment calls and triaging, and also emotional support, I think, it's hard in these times. So that's what I've been trying to do my best to call my lead, sonographers from each site almost on an every other day basis to make sure that they are all, doing well, or at least shoot a text and saying that they're okay or not, and those type of things. So morale and, and protecting them from infection. So in terms of your question about the high intensity vascular medicine, Gary Ansel and, and our group here, we are on a group call about what are the procedures that we need to do. And, we're talking about how to take care of, potential high-grade carotid stenosis with high-intensity statin therapy, and how to take care of claudicants, even the Rutherford 4s, to have a home supervised exercise program, which actually NHS has one protocol for it. So we're kind of, I started smiling when people are talking about these, and I'm like, we all are becoming, real vascular medicine specialists here, pushing the limits of medical therapy in this time. So I think as physicians, we just need to morph with what we have and kind of use the tools that are at our disposal to kind of, fight the situation we're in. I hope I answered your question.
No, you did, for sure. So let me run a case by you that I just saw yesterday. The patient is in his mid 40s, has a carotid on one side and a 90+% on the other side with a velocity of 450. Telemedicine visit today. He said he had a visual disturbance today. Put him on intense vascular medicine therapy. Is this an emergent case?
Well, is it? I mean, if it were not COVID situation, probably it would be, right? But, now we're talking about really asking the question about whether to bring that patient in and expose him or her. I didn't remember if it was a male or a female, but, to do that, or, just, put them on high intensity statin therapy. And also we have Compass trial regimen now, for if the patient did not have a prior stroke or bleed. All of those things are now we are discussing in these patients, right? Without knowing the full history and risk for this patient and the comorbidities, I can't tell you whether, this patient needs to go to the cath lab tomorrow, but, or surgery tomorrow. But, the discussion is completely changed, Tony. I mean, it reminds me of my internship in India, where we had very limited resources in terms of diagnostics, and we saw 100 patients in a morning clinic, and there was no charting or electronic medical records. So it's kind of, like I said, we We just have to use what the tools at our disposal in a given situation here. So what did you end up doing?
Well, he's on for Tuesday, and unless he doesn't have any more problems, I'm going to probably cancel him. I mean, he's on the schedule, just held a spot, and he's on high intensity medical therapy. And I'm going to probably speak to him each day over the weekend and see if anything's changed and try to put him off. But, like I said, occlusion on one side, velocity that's, in the high 90% on the other side, and now with the symptoms. So we'll see.
Yeah.
Let me get to John Runbeck, who's had the most experience with taking care of COVID patients and in the sense of paid the highest price for that as well, direct exposure. And if I can share your story with this group, I think it would be very interesting for people to hear how you've experienced COVID. You're in New York and in a high density population area as well. And you've experienced this firsthand. Tell us a little bit about what's happened to you, John.
Thank you, Tony. Thanks for inviting me to participate. And, God bless to everybody out there. Stay safe, please. So I'm going to sort of tell you two things as part of my personal story. And obviously I'm sensitive of time. So I'm a COVID-19 patient recovering. And I think there's a real warning here in the sense that I probably was exposed on or about March 4th or 5th, probably by a patient who walked in. We have 3 hospitals and 2 outpatient centers in New Jersey and New York. Our biggest hospital is actually in New Jersey, in Teaneck, where we now have 100 cases, 25 patients on vent. It's only a 350-bed hospital. So we've been overwhelmed. But, clearly prior to this surge and this outbreak, it was in the community, and we didn't even know. So presumably a patient walked in, and just in office hours on one of those days, I was exposed to that patient, had no way of knowing, to not wear a mask, when examining a patient and talking to them, probably one of my critical limb ischemia patients. I know for a fact that one of those patients who had a painful non-healing ulcer, we treated successfully, was readmitted the following Thursday with respiratory distress, hypoxemia, and COVID. And subsequently is on a vent at the hospital. But of course, that wasn't his problem. He had a little low-grade fever, but of course he had an infected foot. And we had no way of knowing. So I think that's sort of the personal warning. My experience is that, we have to assume we're getting infected by every patient walking in. So the reason to really only do elective things is that we're exposing ourselves and then exposing others. We just don't know. We're being exposed in ways that we can't possibly anticipate. And I can tell you firsthand, it's a bad bug. I mean, I'm on the mend now. I'm afebrile for 48 hours, but there were 5 days there where I was really very ill with high fevers and bad cough. And fortunately, I recovered. The second part of this is that other than those 5 days from Thursday through Sunday, I've been using my time at home taking care of patients, triaging patients. And this will transition, Tony, really very nicely what you do. So, we have a very active practice, particularly a critical limb ischemia practice. You can imagine at 5 centers, there's a lot going on. And, what the hospital started doing is just canceling those patients. And I pointed out, these are patients who have active wounds. They're in the midst of therapy. They've been treated recently. We can't just cancel their appointments. We need to have communication with these patients. So I've actually been very busy at home, taking the role for me and my partner and all my associates, calling every single patient and following up on them and triaging them appropriately and making plans. I'd love to hear your experience. We tried to institute 2 telemedicine platforms, but unfortunately, most of our patients are elderly and we're not capable to download the platform or we're not give consent to telemedicine, which are 2 integral parts in New Jersey, New York. So in essence, I've just been speaking to the patients, providing good care, triaging them. And in the course of this, in the course of the calls that I'm taking, we've had over the course of my 2 weeks home, about half a dozen patients who are emergencies. Some patients we were following and some patients I had calls who we've had to send in. What we're doing is we're revascularizing what we can and sending them home, not admitting anybody to the hospital, trying to keep them out of the hospital as much as possible. So those have sort of been my lessons learned, both in terms of the risk to all of us, and secondly, in how we need to continue to care for our patients. CLI is it is not an elective thing. There are 300 amputations every day in this country, so it's a serious matter, and we just have to be really on top of our patients and cognizant of their current status. delay if we can, but don't delay if we must.
No doubt. We've definitely learned about what's elective and what's not. And, you know, CLI is something that I think has gotten more awareness, but there is a fair amount of CLI that still goes ignored. And I think that when push came to shove, as Nitin mentioned, as Sahar mentioned, it was on every list of non-elective. So I think if nothing else, it increases the awareness of something that's kind of near and dear to our hearts as far as care goes and patients that we really care a lot about. No doubt.
Hey, Tony, John, first off, get well soon. Hope you feel better. And thanks for all this perspective, all the perspective that you gave us. It's very important. Tony, you've been on the forefront of this telemedicine thing, and you know we've seen on social media quite a bit of innovation. I think necessity is the mother of all inventions, right? So tell us what you have been doing, and you know anything you want to tell the viewers about, you know, the coolest invention or gadgetry or things down the pike coming down that would help to be as real as possible with patients remotely.
Yeah, no, thanks, Raghu. I mean, I think that there's always good that comes out of these horrible tragedies. And I think that one of the things that's coming out of this is that people are recognizing that untethering patients from hospitals and from offices is the reality of where the healthcare system is going. I actually, before all this started in November, decided that I was going to go into a practice and build on my 20 years of cardiac and vascular care, but couple on top of that a connected cardiovascular program, which included telemedicine, telehealth, and remote physiologic monitoring. And with that, we've partnered with companies that have devices which are medical grade devices that can identify, for our population, cardiovascular patients, they can identify irregular heart rhythms at a very high sensitivity, blood pressure cuffs and weight scales for heart failure patients, atrial fibrillation patients, and cardiac patients. But also there's companies that we're partnering with that have socks that are wearable technology that can tell the heat and cool segments of the foot to tell if neurotropic ulcers are forming. I just had a call yesterday with a French company that has a ring device that measures oxygen saturation, et cetera. And so what we're trying to do is try to tailor devices to sort of untether the patient care so the telemedicine piece can really be useful, because as John and the others have recognized, it's challenging for patients to be able to even get on the apps and to be able to communicate with their physicians. And we basically turn this switch on in our electronic health record because of the small, nimble nature of the practice. Basically, we're able to do it the next day. I know that my former practice, which is part of a large group and also part of a large healthcare system, still is trying to figure out how to do telemedicine, but it's just the nature of the way that the practice can adapt. And I think that this event, this pandemic, is creating an environment where I think everyone will say, I'm not just going to do telemedicine right now or telehealth right now. I'm going to actually start to understand the infrastructure and the tools that are out there to be able to then implement this in the future. So when I'm caring for patients, not necessarily during a critical portion of this type of environment, but just between office visits, between hospitalizations, as John was mentioning. I mean, critical limb ischemia patients and other types of vascular patients, they deserve more of a check-in than every 6 months or every few months. And I think the point is that we don't have tools to do that. So I'm working with a digital company right now. We're creating a sensor that has the ability to just place a little patch in 5 different places. And the patches are basically little tiny microphones to make it simple. And they upload by Wi-Fi. And so you can just turn on a patch in each location. Say, I'm listening to the aortic valve, I'm listening to the mitral valve.
Wow.
I'm listening to a breath sound, I'm listening to a carotid bruit. Put this on your foot now, I can listen to, because what we're missing right now is the ability to really take the patient examination. And as you know, Raghu, from your training in India, I mean, your stethoscope pretty much told you everything. So
Right.
the problem that we're having right now is that the digital stethoscopes that are out there right now, and there's several companies that I've spoken with, they're just super expensive. and they're trying to be too much. And when I'm talking to companies and engineers, I had a call with an engineer a couple of days ago, and I said, quit trying to build a Ferrari. All we're really trying to do is trying to build something that I can tell whether the patient has a heart murmur, has congestive heart failure, has a vascular pulse or a Doppler signal, has a carotid bruit or not. I mean, we're talking about very simplistic examination, because that's a huge part of our triage decision. Of course, the history is the first part, and then one or two pieces of information, if we could get that. And so I created a prototype the other night, just out of household stuff. I was able to create some heart sounds, and I sent it off to a buddy of mine who's an engineer, and I said, put some headphones on and listen to this. And he says, what is this? And I said, what does it sound like? He said, it sounds like heart sounds. I said, yeah, I made that out of $14 of equipment out of my garage, and 13 of it was where the mic was because the microphone cost $13. Stuff out of the garage. So the point is that I just need engineers and others to recognize that we're not trying to build really high intensity things. We're just trying to create an ability to sort of untether the patient care. And I know that this is the stimulus for a lot of that imagination. So hopefully some good will come out of this, and a lot more patients will have access and reach, and we'll be able to take care of them better over time as well. Any other comments from the rest of the guys? I'll open it up.
The only comment I want to make in sort of our experience, and ask you yours, Tony, and doing the telemedicine is what's been the patient feedback? We found that it's actually remarkable, especially in this time when everyone's scared.
Yes.
We call the patients, they have been extraordinarily appreciative of our reaching out to them. So I wonder if others share that, yeah.
Same thing. I think that the technical challenges are real. We have 3 platforms that we use for patients, and one is embedded into our EHR, where they just go to our portal, and since they're already lined up on the portal, they hit one button and they can get on. But our patients aren't able to sometimes even do something as simple as that. So then we have some other backups. A lot of people use DoxyMe, and I've been using that for a couple of years for other entities. And my wife's med spa uses that. And there's also the ability now, Greg Abbott in Texas has said telephone calls constitute telemedicine, and FaceTime. We're concerned about FaceTime, obviously, because it is not HIPAA compliant. It also shares your phone number and your address for your Apple ID and some other things you may not be aware of. But I figure if we get to the point of FaceTime with these patients, it's likely because they couldn't get on the app, they couldn't get on Helo, they couldn't get on Doxy. So for them to use my Apple ID is pretty unlikely for them. But it's a reality.
Yeah, that is a reality.
How about you, Sahar?
Just, if you're calling from home, obviously there are various apps which will give you a phone number that you can use.
Right.
Or that will, even if you're calling from home, will put your office phone number in.
Doximity does, yeah.
Exactly, Doximity does that. So it's important for those of you who are trying to stay home but want to call their patients and not reveal their identity, they use Doximity or one of these other apps like Google Voice does it. Yeah.
Right.
Yeah. And I want to open up on our website at VIVA. We're going to be posting all of the document statements that came from SIR, from ACC, from SCI, just so we can just start sharing as a community some of the things that are out there. Maybe not everyone's aware of that. And then we also want to direct you to Twitter to be able to just keep this conversation going, because if there's things like you just mentioned, John, with Doximity, or maybe Sahar, you have something that comes up that makes sense for us to share, just keep that stream going, because I think we're just literally every minute and every day we're learning something. I mean, this morning I checked to see how many cases there were in the US and went from 83,000. And we just looked again on that Johns Hopkins list from the 27th to now it's like 97,000. So it's like we're starting to see everything's changing quickly. The cardiovascular effects of COVID-19, or we're learning more and more about.
Right.
7% are having arrhythmias. There's other problems going on. Our vascular patients are having other issues.
Thrombosis, yeah.
So there's a lot to learn.
Yep.
All right. If there's no other comments, I'm going to close and just want to thank all of you for taking the time for just joining us today. And we want the conversation to keep going. It's our heartfelt desire that these events that have occurred are really the emphasis for us to try to do a conference like this. The very patients that we care for and that we manage every day, and we have personal relationships, as many of you mentioned, and professional relationships, they affect us every day. And we want to make sure that our care for them is the best possible, and we're not limiting that care as if we don't have to, but we're also being very careful about not spreading this pandemic any further than it is. And I thank you, and I hope everybody stays safe and healthy. And I'm glad you're recovering, John.